Good evening. I want to welcome you to the Exam Pro Oral Board Prep webinar for Tuesday, October 4th, 2022. Tonight is a caseless defense type of webinar, so we are going to go ahead and get started. Before we begin the actual webinar, I'm just going to go through the GoToWebinar control panel. The little orange box with a white arrow allows you to collapse or expand the control panel so you can get it out of your view during the webinar. The audio portion of the control panel is very important. By default, the system will usually accept your computer microphone and speakers as your audio mode of participation. If you would like to use a telephone, which can be very useful if you're in an area with a lot of background noise, you can do that by clicking Audio Setup, choose Use Telephone, and then you'll be given a number to dial in, as well as an access code and an audio PIN number. You must enter that audio PIN number if you want to participate in the webinar. If you fail to do so, I will not be able to unmute you. We do not use the type in question part of the software, so please don't type anything there. I will not know that you did that. But instead, we use the raise a hand feature, and this is how you will participate in the webinar, for instance, by volunteering to be in the hot seat. I do want to mention that our webinars are recorded, so if you need to get access to a recorded webinar session, just contact the staff at Exam Pro if you have any questions about that. And with that said, we're going to do caseless defense tonight. So what I'm going to do, this will be the opportunity right now for people who are interested to click the raise a hand feature to get my attention that they want to get in the hot seat. I'll try to get as many of you in the hot seat as I can. I am going to collapse the slideshow here so that we can look at the case lists. And what I'm going to do right now is I'm going to go ahead and go to my software and look for people with a raised hand. Just give me 1 second. All right, I'm going to go to Dr. Page. Are you there?
Yes.
Okay, if it's okay, I'm going to get you in the hot seat first. Let me just find your case list. Which list would you like me to look at?
You could choose.
All right, sounds good. I'm going to go to your OB list if that's okay.
Yeah.
And just give me 1 second as I look through the list. Let's talk about case number 14 for a second. So I noticed in this case that this is a G2P1 and the patient had a short cervix and received progesterone. Did this patient have a history of preterm delivery?
I don't think she did.
Do you routinely screen for cervical length during pregnancy?
Yes, so at my institution, every patient gets a cervical length measurement with the anatomy scan.
So what would you consider to be a short cervix, and how do you manage a patient with no prior history who has a short cervix based upon whatever criteria you're going to tell me?
Mm-hmm. Yeah, so short cervix would be less than 2.5 centimeters. In a patient with no history of preterm delivery, the first thing I always do with a new diagnosis of short cervix is to do a digital exam. If their cervix is closed but shortened, then I recommend vaginal progesterone, starting at the time of diagnosis and continuing until 36 weeks. if I did find that they had asymptomatic cervical dilation, then they could be considered for a cerclage.
Okay, so let me ask you this. How do you dose the vaginal progesterone?
So either a dose of 100 or 200 milligrams is appropriate. I normally give 100 milligrams in a tablet form that's inserted vaginally nightly. It can also be in the form of a suppository, but that typically requires a compounding pharmacy.
Do you offer them intramuscular progesterone as an option?
Not for short cervix. It's the vaginal route of progesterone is what's been shown to be efficacious at decreasing rates of preterm delivery in these patients.
When you are assessing for a short cervix, does it matter whether you use an abdominal probe or a vaginal probe?
I believe the protocol at our institution is that they start with the trans-abdominal probe, and if the cervix is greater than 3 centimeters trans-abdominally, they just report that measurement. If it's less than 3 centimeters trans-abdominally, they do a transvaginal measurement for a more accurate measurement.
If this patient had a history of a preterm delivery, spontaneous preterm delivery, I'm talking about, how would it change your management from what you've already told me?
So if she had a history of a spontaneous preterm delivery prior to 34 weeks and now a short cervix, then we would consider her for cerclage. Vaginal progesterone would also be an option. And then we could also talk about intramuscular progesterone.
Okay, so if you were going to place a cerclage, what kind of cerclage would you place?
So at my institution, MFM does the cerclages, but I typically, if I were the one to do it, I would do a McDonald's cerclage.
Can you tell me how to do a McDonald's cerclage?
So a McDonald's cerclage doesn't require any dissection of the bladder off the anterior or after off the lower uterine segment. So I would do this with an epidural or spinal, and I would use a permanent suture and do 4 sutures starting at 12 o'clock and going to about 10 o'clock, and then maybe 8 to 7 o'clock, and then 5 to 4, and 2 to back close to my initial stitch, and then do a knot, and then I typically would do then an air knot above that.
What are the risks of cerclage?
Risks of cerclage would include PPROM, choreo, neonitis, yes, cervicitis. You want to labor. If they are laboring, then there would be a risk of cervical laceration if they dilate with the cerclage in place.
At what gestational age would you consider it appropriate to place a cerclage?
I would say the upper limit would be viability. So max beginning of the or late 22nd week.
Okay, what about,
in terms of the
yeah, go ahead.
starting gestational ages, if it were a history indicated cerclage, could do that around 12 to 14 weeks, or for someone with a prior preterm birth but no history of cervical insufficiency and then a short cervix, we place it at the time of diagnosis if that's prior to viability.
And when would you take the cerclage out?
36 weeks.
All right, I'm going to stop there. This seems like a topic you know pretty well. And
Thanks.
I don't have any criticisms of anything that you told me. I will just say that when you are diagnosing a shortened cervix, and I think you made this clear, but I just want to reiterate it, the preferred approach is a vaginal probe. And in your case, I think what you were telling me is if the cervix does not appear shortened, then they may not do the vaginal probe based upon a 3 centimeter cutoff, I think you said. But if you are going to make a management decision based on a shortened cervix, that measurement should be made with vaginal probe ultrasound, just because that's the way that the studies were done that developed these protocols. Okay, I think that's what you said as well. I don't have any other criticisms. I thought you did a really nice job. Do you have any questions for me before I let you out of the hot seat?
No, thank you.
Thank you. All right, I'm going to mute you again. I'm going to move to the next person. I'm going to go to Dr. Are you there?
Hello, yes. How are you?
Good. Is it okay if I come to you next?
Please.
Which list would you like me to pull up?
Maybe the office list?
All right. Oh, I probably went the wrong direction. Hold on one second. Sorry. There it is. And give me 1 second just to look at what the options are here.
Sure.
All right, let's talk about case number 16.
Okay.
So this is a case of a patient who is not menopausal. She's perimenopausal.
That's correct.
Why did you do the FSH?
It was per patient request. We were trying to understand if her symptoms were from hot flushes going into menopause or if there was something else going on.
Okay, so she's still got menstrual cycles happening, right?
Yes. I also wanted to determine whether this was postmenopausal bleeding or sort of abnormal uterine bleeding because of anovulatory bleeding as she was transitioning to menopause.
Okay, so tell me, how would you define menopause as far as the diagnosis of menopause?
Absence of menstrual cycle for 12 months.
Okay, so then postmenopausal bleeding, in my mind, would be bleeding that occurs after a patient has 12 months of no bleeding.
That is correct.
So how does the FSH help you?
That is a good point. I probably shouldn't have said that. I believe it was patient request, and we were just trying to understand if we can gauge, the timing of her transitioning. This is going to be a longer or a shorter period, but I would have to look up the details of this case.
Okay, you did an endometrial biopsy, and I think that is reasonable given that she's got abnormal uterine bleeding and she's of the age that she is. What were the results of the endometrial biopsy?
It showed benign endometrium.
Okay, so what was the counseling that you did regarding the levonorgestrel IUD?
The bleeding was bothersome to the patient. It interfered with her work, and she was missing the cramping she was experiencing was significant, where she was missing a day or two of work. and she wanted to get options in terms of what she could do during this period. And we discussed, perimenopause could last 1 to 3 years. And I sort of discussed her options in terms of helping her achieve amenorrhea in that period of time.
Which levonorgestrel IUD did you place?
Mirena.
And if she did get amenorrhea, then when would you take the IUD out?
I would probably leave it for 5 years or so, until 5 to 8 years, or at patient request, since it can protect the endometrium from hyperplasia as she gets older.
Now, you also talked to her about hormone replacement therapy. What did you tell her?
So we discussed sort of the risks and benefits in terms of hormone replacement therapy for women who are having a significant hot flushing. And we discussed the results of the Women Health Initiative study. We discussed sort of the increased risk of thrombosis, DVT, and stroke that is rare, sort of in the order of 5 to 8 per 10,000, with significant benefit to her quality of life. Given that she has a uterus in place, if she had the Mirena IUD, we wouldn't have to place her on any oral progesterone, and that would be a benefit as well.
Okay, I have 2 questions for you. First is, if she was going to go on hormone replacement for her hot flushes, what preparation would you recommend?
I would recommend a transdermal preparation, estradiol, as a first option.
Why would you choose that?
Again, it's suggested that the risk of thrombosis is even lower because of lack of a first pass effect through the liver.
Did you discuss any other treatment options for her hot flushes besides hormone replacement therapy?
Yes, we discussed sort of non-hormonal options, as well as alternative, increasing physical activity, making sure that she has a cool ambient temperature. Also benefit of things like acupuncture, and I think I mentioned exercise.
Okay, when we talk about non-hormonal treatments, what treatments are you referring to?
SSRIs, for example, paroxetine, venlafaxine.
All right. I'm going to stop there. I'm going to give you a little bit of feedback. I think the discussion was very good. The only thing I don't like about this case is the FSH, because I don't think the FSH is not particularly helpful. It's going to be elevated. She's
Right.
54 years old.
Right.
And there's no scale by which to judge the degree of elevation. So, it's not like if it's 40 versus if it's 20, that you're going to be able to really tell her anything.
Yeah.
I think that the examiners are sensitive to the overutilization of certain laboratory tests that don't really offer much benefit, and this is one of those tests.
I see.
So I think about the best defense. No, I do want to back up for a second. If she was 38 and she had symptoms of menopause, then an FSH is completely appropriate. Okay, but when a patient's symptoms and age are consistent with the natural transition, so either perimenopause or menopause, then I don't think that the FSH is considered valuable. Now, other testing, maybe, like maybe a TSH, possibly, could be part of this evaluation, but I'm not saying you should have done it. I'm just saying the FSH to me is not as valuable. But if you take that out of the discussion, the rest of the discussion was very, very good.
Okay.
I don't think of a levonorgestrel IUD as useful in a postmenopausal patient. It's not a treatment for postmenopausal bleeding, but this patient is not that patient. This appears to be a patient whose transition to menopause is coming a little later than the average. By the way, what would you consider to be the average age of menopause in the United States?
I usually consider it 51, 52.
Yeah, I think 51 is the number that you find in the references, and again, it's just a marker. It's not a rule, but it's just kind of a, if you will, statistical sort of average. And so yeah, this patient's a little bit older. I would say for the levonorgestrel IUD, the duration of effectiveness for any bleeding symptoms is probably going to be in the order of 5 to 6 years. The amount of hormone in the device does decline, and the pregnancy prevention is probably more a foreign body effect than the hormone itself. But if she gets 5 years out of it, she'll be 59, and she really shouldn't need it. So I thought that 5 years is a good answer for that. There's no reason to take it out any sooner unless she's having a problem. And then you have a very high chance that when you do remove it, she'll remain amenorrheic. Okay?
Sure. Yeah, I have a
questions?
question in terms of, you said, how would I discuss the FSH if it's brought up? I mean, I'll look into, but from what I remember, I think it was a patient request, but I still should probably.
I think that's about the best answer. I think in a case like this, there's several ways you can discuss this. One option is to say, I debated about putting this patient on my list because I really don't recommend FSH.
Okay.
It was a request. I decided to put her on the list because this is something that happens. Patients will come in, they request something that I don't think is particularly useful, but it's an opportunity for me to counsel them. And so I counseled her. And at the end of the discussion, we had a shared decision making. She preferred to have the test, even though I told her I really didn't think it was very useful. But rather than have controversy, I felt like, everything else was reasonable. It's not a very expensive test, and I went ahead and I ordered it for her. And I think that's okay. I don't think it's a great answer, but I think it's it's reasonable. Okay.
I appreciate that. One other question.
Yeah.
In terms of IUD, I mean, my reasoning is estrogen-only hormone replacement therapy is preferable to the progesterone and estrogen. Is that fair?
Yeah, I love it. I mean, I think the levonorgestrel IUD is going to treat her abnormal uterine bleeding, and if you're going to put her on estrogen, it's going to protect her uterus. If we're talking about a 52 milligram device, either the Mirena or the Liletta. Also, I like the fact that you did mention transdermal. This is an important point for everybody listening. The preferred estrogen route of administration would be transdermal because it is associated with very, very low, some people say 0 risk of VTE. I think that may be a little bit of an overstatement, but I've seen it in writing. So again, I like it. I thought the discussion all the way around was good. The only thing I don't like about the case is the FSH, but it is real life because patients do come in and ask for it. So I think it does present an opportunity to discuss your counseling, which I think you did.
Thank
so
you.
The number one thing is be honest in the exam, but try to frame it in a way that makes you look as good as possible. Does that make sense?
Yes, thank you.
Yeah, good job. I'm going to mute you, and I'm going to get the next person in the hot seat. We're going to keep moving. Try to get as many people as we can. Dr. Shelton, can I come to you next?
Absolutely.
Which list would you like me to pull up?
I am fine with any of the above.
All right, well, I'll tell you what, we did office and we did OB. So how about if we do GYN?
That sounds great.
And give me just 1 second to look at the list. Okay, let's talk about case number 24. You
Yes,
operate
sir.
on this. You operate on this patient twice.
I did.
Why?
So initially she presented to me with a complaint of pelvic pain. She had a transvaginal ultrasound that showed a right adnexal cyst, and she desired surgical management. As it states, she's 59. So it took her to the OR for diagnostic laparoscopy with planned excision of the right ovarian cyst. When I got into the abdomen, I typically do single site initially for diagnostic laparoscopies, and often, if the mass is appropriate, can remove it through that single incision as well. When I got into her abdomen, she had significant adhesive disease of the entire pelvis, and I didn't feel like I could safely perform the procedure, and concluded that a majority of her pelvic pain was probably related to her adhesive disease rather than just her right adnexal cyst. So I spoke with her husband prior to aborting the case just to confirm that he was okay with that plan, woke her up, brought her back to my office, and discussed surgical management with definitive hysterectomy, bilateral salpingo-oophorectomy, lysis of adhesions, and the remainder of the procedure that I performed.
Okay. Now she's 59 and she has a symptomatic right adnexal cyst. How big was the cyst on the initial imaging?
7 centimeters.
So was there any concern in your mind about the possibility of this being a ovarian cancer?
So we did discuss the risk of that. It had been seen on previous ultrasounds prior to her care with me, and so it was stable in size. We discussed the option of seeing GYN oncology for management, and she preferred to stay in my office for my care.
Did you do any evaluation besides the ultrasound?
No, we did not.
No tumor markers?
No, sir.
Okay. Now, let me ask you this. Well, I'm going to ask you, how did you counsel her about removal of the other ovary if it appeared normal?
So the diagnostic laparoscopy showed that the pelvis was completely abnormal. So there was actually a cyst on the left side as well. And taking it all out and sending to pathology, we realized that these cystic structures were actually hydrosalpinx that were plastered down into the pelvic posterior and left and right pelvic side walls. So her ovaries were actually normal, but the cystic structures that were seen on ultrasound were actually her fallopian tubes.
Why did you do the cystoscopy?
So because of her significant adhesive disease, I was concerned and wanted to be sure at the end of the case that I had good efflux from both ureters, just because of the proximity of those masses bilaterally and the extent of my lysis of adhesions that I had to perform to complete the case.
Tell me where you would find the ureter in the abdomen and pelvis.
Right, so in the abdomen, it's about 15 centimeters long. It exits the renal pelvis, moves laterally to medially across the psoas muscle, and crosses the pelvic brim over the bifurcation of the common iliacs. As it goes into the pelvis, it also moves lateral to medially, crosses over underneath the uterine artery, and then anterior medially into the bladder.
Now, you had done the diagnostic laparoscopy, so you know this was going to be a difficult case. Did that change your management of the hysterectomy from a routine hysterectomy in any way?
So yes, sir. I counseled her that the best approach, and again offered her referral to GYN oncology, given that I assumed this would be a difficult case. But I counseled her about the possible need for assisting hands from urology or general surgery. I operate at a block time where a urologist is available as well as general surgeon close by, so they were aware. We did discuss stent placement. Fortunately, this patient had a very low BMI, and I had discussed the option of stent placement with her, but didn't feel like it was necessary. Once I got into her abdomen, robotically was able to peel a lot of that adhesive disease off without any major dissection.
What do you think was the cause of all those adhesions?
I think the history of her PID. So she had early diagnosis of PID in her teens to 20s years, had significant difficulty with fertility following that, and never really could get ahead of her pain despite management from multiple physicians.
What organism would you guess caused the PID just based on statistics?
Gonorrhea.
All right. So let me do this. I'm going to give you feedback. I thought that was a very thorough discussion. Are you anticipating this case could be asked about?
Of course.
Okay. Yeah, it's a very nice case because it all turned out really well. And I think it demonstrates a couple of points. One of them, the first question I asked you was you operated on her twice, like as if you're trying to increase your productivity and, you know, kind of should have done it all in one, which is not true. I completely agree with the approach. I think one of the things examiners respect and appreciate is when we have a case that isn't going the way we thought it was going to go, and we can step back for a second and say, well, maybe I need to have more than one episode of care. You know, sometimes it's a case like this where you really didn't do anything other than just an evaluation with the first surgery, which is always frustrating because you feel like you didn't treat the patient, but you really did the right thing. Sometimes it can be like in the case of a hysteroscopic myomectomy, knowing when to say, okay, I've got half the myoma, I'm going to do a staged procedure. You know, sometimes it can be where you realize that your risk of a complication, whatever the case may be, bleeding or injury is high, and you abort part of a procedure that you had intended to do that's not absolutely required. So again, I think it's always okay when you step back and you change your plan if it's done for the right reasons, which in this case, it looks like it was. I would say the only thing I would, and I'm going to have to look it up, but my thought is that the more likely organism for this degree of adhesions, thank you, I would probably guess chlamydia. I can't, you know, I'm gonna have to look it up to see if there's actually a statistical, you know, you could always say multiple organisms, but I think that's a cop out because, you know, we do say that a lot. I really think chlamydia is probably more likely, but again, I'm not gonna fault gonorrhea. I think gonorrhea is a good answer, especially if I think of a patient with gonorrhea probably being more symptomatic if they were this sick, where chlamydia may be less symptomatic, but that's again a generalization, so I should probably leave that out of this discussion. I love the discussion of the ureter. I think this is absolutely the kind of case where discussion of the ureter comes in, and I thought the discussion of the ovaries was very appropriate. This is not really the kind of case where I think about trying, especially in a 59-year-old, trying to salvage the ovaries where you had all the adhesions. So I thought that was a good discussion. So do it just like you did it today. I really liked it. Do you have any questions for me?
No, sir. Well, I guess one, should I go more in depth with the discussion of the ureter? I kind of just like.
No, I thought that was fine. And then, you know, the thing I'm always thinking when I think about the ureter, when I'm in surgery or when I'm talking about it in, for instance, this kind of a setting, is as I'm describing the course of the ureter, I always think about the places where I'm likely to injure it during surgery. And so, you know, that's, I think, the discussion that might come up is they might ask you about that. The thing people sometimes forget to mention, and I think this is appropriate, especially with laparoscopic robotic cases, is when you close the cuff. You know, if you're disoriented at all, if your bites are too big because you're worried about taking too small bites, you could potentially get the ureter when you close the cuff, but it's not the most likely spot. I think it's much more likely either with the IP or when you are taking the uterosacral ligaments or the uterine arteries. So, all right, good job. I'm gonna let you have the hot seat.
Thank you. Thank
you. And I'm going to get the next person. We're going to keep moving. Let's see, who do we have here? Sorry, the software is moving too fast for me. Let's see here. Come on. Dr. Wagoner, can I get you in the hot seat next?
I think that's me, but I'm not sure.
Yes. Yep.
Okay.
You can talk. It's you. What's your last name?
Well, I have two last names, but Claros Wagoner.
Okay. All right. Is your case list going to be under Wagoner?
No, under Claros, CLAROS.
There it is. Okay. I'm glad you told me that.
Yeah.
Which list would you like me to look at?
Either one. I don't have any preference.
I'll tell you what, how about if we'll keep going kind of in the order we've been. We'll go to office. Okay, I want to ask you this question. In case number 19 and case number 20, it looks to me like you have basically the same case. Patients are similar in age, neither of them have children. Why'd you give two different medications?
I actually use both clotrimazole and fluconazole fairly often. I feel that depending, just in my practice, I've seen that sometimes clotrimazole will work better if they have like a lot of vaginal symptoms. And then I also do ask them if they are comfortable doing a vaginal cream or if they prefer a pill. And so just based on that discussion, we choose either one, either the clotrimazole or the fluconazole.
Okay, so tell me about the dosing regimen for each of those.
So the fluconazole would be 150 milligrams. It's a pill that's taken once. You can offer it a second time to be taken the next day if their symptoms are severe. For the clotrimazole, it is a cream that is done nightly for 7 days, and it's a 2% cream.
Okay, now I noticed that your evaluation included a comprehensive vaginitis panel. What do you test for?
So it's actually a swab that our institution uses, and it tests for trichomonas, BV, and yeast.
And what type of testing is being performed?
It's PCR testing.
Okay. And if the patient did not improve with your treatment, what would you do next?
Let's see. So I would say bring her back to the office, do another vaginal exam. Sometimes I then, if I'm still thinking that it's yeast, then I will sometimes try another medication for yeast and see if that resolves her symptoms.
Do you ever see patients who have more than one infection at the same time?
Yes.
When you do, what is the most common scenario that you encounter?
Yeah, I would say the most common scenario that I encounter would probably be BV or bacterial vaginosis and yeast.
And how do you treat BV?
BV, you can treat with Flagyl, 500 milligrams twice a day for 7 days, and that's oral, or you can give them a vaginal cream nightly for 5 days. Yeah.
So let me ask you this. Is BV Sexually transmitted?
I would say that it's not.
So do you give patients any recommendations regarding intercourse during treatment?
I usually do not. I do tell them that BV can sometimes be brought on just due changes in vaginal pH after intercourse, but I usually do not give them any recommendations specific about intercourse during treatment.
All right. So I'm just give you some feedback. I think the discussion. Oh wait, I want to ask you one other question before I give you feedback.
Okay.
Can you tell me AMCEL's criteria?
Yes. So AMCEL's criteria is the gold standard for diagnosing BV, and that includes having on the wet prep more than 25% clue cells or 20% clue cells, having a positive whiff test, having a pH that is, I believe it's a little bit more basic. I would have to look up this specific value than the normal vaginal pH. So I'm gonna say it's above a pH of 4.7. And then the presence of like gray discharge are the 4 criteria.
Okay. So now I'll give you the feedback. I would agree. I think with AMCEL's criteria, the way you described it is just fine. The grayish discharge is thin rather than thick and clumpy, usually kind of coats the vaginal walls. That's the way I always think of it. That I agree with the pH, the whiff test, and the clue cells, 20% in your high-powered field coated with bacteria. The one thing I will say about BV is if you actually look this up, you'll see that it's generally recommended to tell patients to abstain from intercourse during treatment. It's not sexually transmitted, but it is quote unquote somewhat sexually associated because, as you mentioned, some of the changes in the vagina that can occur with intercourse can promote the infection or possibly make treatment less effective. So generally speaking, it is recommended to abstain from intercourse. I think if you look this up, you will find that to be the case. I do want to point out that when patients are symptomatic, so when they come in with a vaginitis and they are symptomatic, other than for an STI, they often do have they'll have both BV and yeast. So I think that's a very important consideration to keep in mind. And of course, now with our testing, the testing is fairly accurate and it gives us a kind of a conclusive result about BV versus yeast or both. And the treatments that you gave and the dosing regimen that you recommended for each of them, I think is completely appropriate. If a patient does not improve with treatment, I think the very first step is reevaluation. Sometimes with yeast infection, we might do actually a fungal culture just to make sure there's not a non-candida a variant species. I think that is everything. What caught my eye about this was, again, 2 different treatments for the same exact presentation because nothing else on the case list really looks different. And pretty good idea what you're going to say, but it's always nice the examiner wants to hear about not so much what you did, but why you did what you did. And you did a good job telling me that. Any questions for me before I let you out of the hot seat?
No, I think that's it. Thank you.
All right, good job. Thank you. And let me get the next person into the hot seat. Dr. Akinwande, are you there?
Yes, I'm here.
Okay, if I come to you next?
Yep, that's fine.
Okay. And I'm sorry about your last name. It's a tough one for me.
You did it perfect.
Which list would you like to look at?
I mean, I guess we can just continue in order. We can do OB.
Okay, sounds good. Let me just pull it up here. Just 1 second. You know what? I think it may be top. Let me. Did you see it? Did I go by it?
No, I haven't seen it. What month is this? I know I submitted it. It was end of September.
Okay,
And
let me
she
look
told me
at the
that
other
that
month.
she got it.
This I think is the October month. Let me go. Let's
Okay.
look at September. Oh yeah, there we go.
Yeah.
Perfect. Let's get OB. And let me just scroll down and see what we have. Okay, let's talk about case number 24.
Okay. Can you scroll up? It's not on the screen.
Oh, I'm sorry. Let me just tell me when you can see it.
Okay, there.
You can see it? Okay, good. So I have a couple of questions. Did this patient come in spontaneous labor?
Da-da-da-da. Yes.
And at what point during her presentation did you diagnose the intraamniotic infection? Meaning,
Uh,
was she showing signs when she presented, or did it develop during her labor progress?
oh, it developed during her labor progress.
Okay, how did you make that diagnosis?
So she had a fever. I can't remember her exact number, but I did give her Tylenol to treat it, and then we checked it about 30 minutes later, and she was still febrile. So with 2 fevers, and she was tachycardic. We gave her, we had, fetal tachycardia. So we gave her the diagnosis of intraamniotic infection, choreo.
So the fetal heart rate tracing, was it ominous?
No, it was not. It
So
was
were
just
you surprised?
persistent. It was just a persistent category 2 tracing despite intrauterine resuscitation.
So were you surprised at the how the baby did once it was delivered?
Um, I was surprised by the numbers being that low, but not completely.
Now, I'm wondering, why was the baby transferred to another facility?
So this was a facility where we don't have a NICU. So the baby needed to be intubated. Yeah, and and I don't remember additional details.
Okay, tell me, how do you calculate an APGAR score?
APGAR, so it's out of score of 10, and there are 5 categories, each with 2 points each. We have activity, pulse, grimace. What's the other A? I'll come back to the other A. And respiration. What is the other A? I can't think of it, but I know there's one. Oh, no. Appearance, I believe, for color.
Okay, so let me ask you this. Did the patient receive a 10-minute APGAR? And if so, or if not, when would you get a 10-minute APGAR?
So I need to look this up. I'm pretty sure she did get a 10-minute APGAR. I believe the criteria for getting a 10-minute APGAR is if you have the 5-minute APGAR score less than 7.
And why was the baby in the hospital for 19 days? Do you have any idea?
So this is me just stalking the chart at the outside hospital. I wrote this down in my thing and now I can't remember. So I need to look it up, but I know they were monitoring the baby for what is it called? There was some neuropathy, like there were some brain issues that they were monitoring the baby for.
Okay.
I don't remember.
Right. Okay, I'm going to stop here. Let me just, wait, no, let me go back for a second. How did you treat the choreo? I totally forgot to ask you about that. I'm sorry.
It's okay. So I treated the choreo with Tylenol and Apogent.
Okay, and if the heart rate tracing had required a cesarean delivery, would you have treated it the same way or would you have done something different?
If she required a cesarean section, then I would add clindamycin.
Okay, so I'm good with the discussion with the APGAR scores. So there's a couple things. One is the fetal heart rate tracing. I could have asked for more detail about describing it. What would you consider to be an ominous fetal heart rate tracing or a category 3 fetal heart rate tracing? I probably should have, but I didn't. I got distracted by the APGARs of 3 and 5. But the bottom line is that I think that the way you handled this case is just fine, except that you do have to know how to calculate an APGAR score. And the things that I think about going into this, the heart rate, the breathing, muscle tone and movement, color or appearance of the baby, that's how I kind of remember that, and reflexes. Okay, those are the 5 things that I remember being with the APGAR. You can get 1 or 0. That's my timer just reminding me to stay on schedule. You can get 0, 1, or 2. So as opposed to like a BPP, an intrapartum assessment where you only get 0 or 2, for the APGAR you get 0, 1, or 2. Total score is up to 10. If the 5-minute APGAR is less than 7, there should be subsequent APGARs assigned every 5 minutes until you get above 7. And the 1-minute APGAR, I didn't ask you this question, but it's not particularly predictive of anything. I think the biggest issue about a case like this, many people will have a case like this on their list where you have a 40-week, 5-day gestation. You have no antepartum complication to suggest that this baby should have trouble. You have a reasonable birth weight, and yet you got 19 days in the hospital. And I think that whenever you have a situation like that, it is useful for the purposes of the exam to go and see what the diagnoses were that were assigned to that infant, and if any of them can be attributed to something that could have been managed during labor or antenatally, meaning if there's anything that the baby has that could have been potentially prevented, then it's good to know about those topics and be ready for it. So I think that's the only thing, because 19 days is really on the outside edge of, I really wouldn't expect this baby to be there that long unless there was something serious that they were worried about. So any questions for me before I let you out of the hot seat?
No, that's it. Thank you.
Yeah, thank you. And let me just get back to the controls here and I will mute you just 1 second. All right, and I'm gonna get our next volunteer in the hot seat. Dr. Cabby, are you there?
I'm here.
Can I go to you next?
Yes.
Which list would you, let me see, you're probably in the October folder. Let me go there and see. And if not, I'll go back. Which list would you like me to pull up?
Any list is fine.
Now, is it under Cabby? Is that what I should be looking for? Am I saying your last name right? Oh, here it is. Okay.
Yeah.
Okay.
Any
You said
list
I can pick. Okay. Just one second. Seeing what have we done more of. Okay, I'll tell you what. Let's go to your GYN list.
Okay.
Okay, so one thing I noticed on your list, you have a lot of postmenopausal bleeding, and
Yes.
in multiple of those cases, you comment on the thickness of the endometrium. So case number 2, I saw a thickened endometrium stripe, 4.4 millimeters. Then I get down kind of on the other extreme, case number 8, 3.6 centimeters. So tell me, how do you interpret an ultrasound with a thickened endometrial stripe?
So normally for a postmenopausal woman, she shouldn't have a lining that is thickened as her ovaries aren't making the estrogen or progesterone. We should normally see a lining that should be less than 4 millimeters. So if it's thickened and she is also having complaints of postmenopausal bleeding, that makes me concerned that there is an abnormality that's occurring.
Okay, so are you telling me that an endometrial stripe of 5 millimeters is not normal?
No.
Okay. Is
If the
there
patient's
ever a
having-
situation? What were you going to say? I'm sorry.
If the patient's having postmenopausal bleeding and it's thicker than 4 millimeters, that's not considered normal. If she's not having postmenopausal bleeding and it is thicker than 1 centimeter, then that is also considered not normal.
Okay, so if a patient has an incidental imaging with a finding of an endometrium thickened more than 1 centimeter, you would consider that warrants evaluation.
Yes.
Okay, give me your differential diagnosis for a postmenopausal patient with a thickened lining.
She can have endometrial hyperplasia, endometrial malignancy. She can have a polyp, a submucosal fibroid, or some of the things that I think of when she has a thickened lining.
All right. So in this case, number 8, the patient had a thickened lining 3.6 centimeters, and you did an endometrial biopsy. If the endometrial biopsy, well, let me ask you this. How did the endometrial biopsy help you decide what to do next?
Normally, I say for patients, if we do an endometrial biopsy in the office and it comes back benign, it doesn't necessarily mean that there may not be a focal lesion that did have a malignancy. But the reason why I do a biopsy in the office is that if it does come back as a malignancy, I avoid taking them to the operating room to do a hysteroscopy D&C and then still having to refer them to gyn-onc and then have another procedure.
Okay. Tell me about the endometrial interepithelial neoplasia system of terminology. Specifically, why is that system recommended?
So I know the old guidelines better, where you have simple hyperplasia with or without atypia, and then complex hyperplasia with or without atypia. I believe with the new guidelines, they have benign, and then Then they have EIN, I believe, and then malignancy. But my pathologists normally use the complex and simple hyperplasia with or without atypia. And that's the one that I'm also more familiar with.
Okay. Do you know the reason why the EIN system has been sort of encouraged or promoted?
I do not.
Okay. All right.
I'd have to
Let me
look that
stop
up.
here. Let me give you some feedback. So first of all, well, I'll just answer the last question first. The EIN system has three components: benign hyperplasia, as you mentioned, EIN, which is a precancerous condition, and adenocarcinoma, which you also mentioned. So it has three diagnoses: benign, precancer, and cancer. And the big advantage of this is that it's a much simpler system for the pathologist and the clinician to be on the same page about what is the appropriate management, okay? As opposed to the older system with the four different criteria or classifications, excuse me, simple and complex, with or without atypia, which is a little bit more confusing about whether it's precancer or not, and whether, and generally we think about atypia as being the concerning finding, and whether or not we need to do one type of treatment versus another. So the EIN system is designed to streamline that. And that's the reason it's encouraged, because it's better communication, more correlation between the diagnosis and the most appropriate management. Now, the other things, one thing I think that we often misinterpret is the 4 millimeter threshold of the endometrial thickness. I think it's probably overstating it to say that 4 millimeters or less is normal and 5 millimeters or more is not normal. What I mean by that is that really 4 millimeters is more reassuring. It has a high negative predictive value for endometrial cancer when the endometrial lining is 4 millimeters or less. But there are a lot of women, like your case number 3, I think it was, or 2, she has an endometrial stripe of 4.4 millimeters. I mean, this is most likely going to be benign, but it's just that 4 millimeters has this very high negative predictive value that is essentially equivalent to a blind PiPel biopsy with a benign result. If you have 4 millimeters or less, the negative predictive value is very similar to those results from the biopsy. Now, that doesn't mean that I'm ignoring a patient whose lining is 5 or 6 millimeters. Obviously, we're going to do a sampling procedure, but I'm not expecting cancer usually in those cases. And then you did mention, and again, please don't misunderstand, I'm still recommending biopsy, like you are. Then we have the patient who has the incidental finding with no bleeding. And I think the way you stated it is probably the best approach. If it's a centimeter or more, it warrants evaluation, although that is not a guideline. I can't give you a reference. It's more of an expert opinion, which has been written about in a number of different references. So in these cases, the common component is the bleeding. For the ones that we were looking at, they're all postmenopausal bleeding. And that's a very important issue. When we talked about the differential diagnosis, the first two things you told me were or hyperplasia and cancer. They're probably not the most common diagnoses, but they're the ones that we're most concerned about. And the key thing with postmenopausal bleeding, as I am fairly confident you are aware, is that it's the presence of postmenopausal bleeding that really leads us to diagnose endometrial cancer so early. And that's why if you look at the APGAR practice bulletin on endometrial cancer, 70% of endometrial cancers are stage 1 at the time of diagnosis. It's probably a lot more likely to be a polyp than it is cancer. A benign polyp is what I meant. So the other thing I didn't ask you, but I'm going to ask you now since I still have you in the hot seat, if you get a result that says EIN, or for your system with your pathologist, complex hyperplasia with atypia, what is the chance that that patient actually has a cancer, but you just didn't pick it up yet?
I believe it's around like 40%.
Yeah, I think that's a very reasonable number. The range is 25 to 40%, but I think a lot of people say actually, favor the higher side of that. And I think that is a really important point. especially if you do, and I don't know if you have this on your list, but some people do have hysterectomies for complex hyperplasia with atypia or for EIN. And if you did the hysterectomy, then this increases the chance the examiners will ask you about endometrial cancer. A lot of people, this is, for instance, in my practice, I would refer those patients to G1 oncology, but there are some health systems and some practices who only refer when the patient actually has a diagnosis of cancer. Either approach is acceptable. Just realize that these are the cases where you'll get asked about endometrial cancer. So I kind of went on a little bit long. I didn't mean to. Do you have any questions for me before I let you out of the hot seat?
I guess the question of like, you know, if she had postmenopausal bleeding and her lining is 5 millimeters, I guess I'm confused on how I answer that then.
Oh, so here's what I would say. I would say it's not necessarily abnormal, but it's not reassuring either. So, you know, I think in the 5 to 6 millimeter, it just warrants evaluation. The other way this might come up is, what if she has a 4 millimeter lining, so you don't sample her, but she continues to bleed? Then you're gonna, you know, you're not gonna say, oh, it's normal, so I'm just gonna blow it off. So the only point I was trying to make is that I think that 4 millimeters is not necessarily quote unquote normal and 5 millimeters is grossly abnormal. I think that the endometrial thickness is just a marker for the relative risk of cancer based upon the negative predictive value. And by the way, when you have a thin endometrial lining, if I was describing this to the examiner, I would say a 4 millimeter lining if I can visualize the entire endometrium and the endometrium is homogeneous. If I have focal areas, abnormalities, then I'm not going to feel so comfortable even if the lining measures 4 millimeters or less. And if I can't visualize the entire endometrial cavity, I'm also not going to feel comfortable because maybe I can't see something that's actually important. Does that make sense? So I think the bottom line is I'm just less inclined to say 5 millimeters is abnormal as much as I would probably say it's not reassuring. And I would warrant further evaluation. That's how I think of it. I think I'm splitting hairs on this, but I'm always really careful about, I don't want to overstate the importance of 4 millimeters. It's useful, but if they continue bleeding, I'm going to reevaluate them with a biopsy. Okay?
Yeah. Okay.
Very good.
Thank you.
Yes, and I did not think that your discussion was at all inappropriate. I was totally following it. I'm just nitpicking a little bit for my own, you know, personal preference. Okay, I'm going to go to Dr. Ramadan. Are you there?
Yes, sir.
Yeah, do you have a question?
I actually did ask a question, but I'm happy to take the hot seat. I was asking, when do you do a hysteroscopy DNC for postmenopausal bleeding if we're actually doing the biopsy?
Do you mean when would you prefer hysteroscopy DNC over a biopsy?
Right.
So I think there are a couple different ways you can answer that. The first thing is whenever you have a focal lesion, it's probably better to do a hysteroscopy DNC because it is slightly more accurate. But some people will say they would still do the office biopsy for the same reason that Dr. Cabby suggested, which is that if they get a diagnosis of cancer, then they'll just send the patient to G1 oncology instead of taking him to the OR twice. But I think it's always, when you have a focal abnormality, preferable to do the hysteroscopy DNC if you can. And if you didn't do the hysteroscopy DNC at the beginning and you did the endometrial biopsy, then you have to think about if, you know, should you go and do the hysteroscopy DNC if you didn't get anything on your endometrial biopsy as far as a polyp or something to explain the focal abnormality. Does that make sense?
Yes, sir.
Okay. Which list do you want me to look at?
Up to you.
All right, I'll tell you what, let's go to office because that's kind of where we're at in our rotation here. And let me see, did I skip by your list? I don't think I did, but they're not all in alphabetical order. So let me just see here. There we go. Let me ask you about case number 4. So I noticed that you counseled this patient on weight reduction. Well, what did you tell her?
So in this case, this patient came in, she's a 32-year-old, she had a BMI of 59, and she had PCOS, and she was being also evaluated for her ovarian reserve and for her abnormal urine bleeding. In her case, with her BMI of 59, we started out with, first of all, we started talking about what her lifestyle is and what her diet is, and her activity every day. And then after that, we started talking about what would be the options when it comes to nutritional, to be referred to a nutritionist, as well as a bariatric surgeon if she wants to go down the surgery route in order to reduce her weight. I would counsel her about the morbidity of her BMI on the long run, so that she can be a little bit more motivated in order to seek help. And there's also a weight reduction clinic, which would counsel her a little bit better than our short time in the clinic about her options.
So would you recommend the patient start the weight loss process with bariatric surgery?
I would not. At least we should start with diet control and trying to assess what the problem is. And after that, we should try that at least for 6 months to a year, see the progress after that. And then after that, we can discuss surgery.
So I agree with you. And I think there's a very important reason not to start with bariatric surgery. Do you know what I'm going to say?
No.
Okay. What is the likelihood of success with bariatric surgery over the long run?
I believe it's about 30 to 40%.
Yeah, and I think a lot depends on the duration, how far out you go. The success rates in the first couple of years are pretty high, but as you get to 5 and 10 years, progressively you get lower long-term success rates. And part of the reason for that is because patients don't make any modifications to behavior other than what the surgery requires. So over time, their eating habits gradually sort of trend back to what they were prior to surgery. So I think that's a really important point. I think that's why it's nice, like I saw that you counseled on weight reduction, you started on not just like referring right away, and obviously your weight reduction clinic probably starts with behavioral modification as well. You'd certainly like to give some time to get the patient at least trying to do a few things that will help her post-operatively to have a longer weight loss benefit from her bariatric surgery. Let me ask you this. Do you have a BMI threshold at which you consider bariatric surgery appropriate as a recommendation?
I do not in my practice. Usually in my practice, which is usually the fertility clinic, we go towards a conversation towards fertility rather than just bariatric surgery for the sake of a certain number with the BMI. So we don't have a cutoff for which number. But to me, if I want to at least start a conversation about weight reduction, or at least refer to a weight reduction clinic, I would at least start with a BMI of 40, and possibly surgery. I think it's above 45. I might be wrong.
What was the last part you said about 45? I'm sorry.
45, I would be a little bit more aggressive about going towards surgery.
Okay. Let me ask you this. You mentioned in this case counseled on metabolic syndrome. What is that?
So metabolic syndrome is a syndrome which is a set of criteria which are the number one, that I think that triglycerides are above 100, blood pressure above, I believe 130/85, HDL below 35, waist circumference above 88 inches, and I forget the last criteria. Might be I think it's a fasting glucose above 100, and it's a syndrome where if the patient meets those criteria, which two of the 5 criteria, patient has a higher morbidity.
A higher morbidity, what do you mean by that?
Cardiovascular wise, more at risk for hypertension, diabetes, and other diseases.
Okay, good. And I think that the thing I always think about with metabolic syndrome is that it is a group of risk factors for heart disease.
Okay.
That's the way I usually think of that. Let me just think here about feedback. The one thing with the BMI for bariatric surgery, I usually think about a BMI of 40, or if they have a medical condition that would be expected to improve with weight loss, then you could lower the BMI below that. I think of 35 as for just an example there. With the metabolic syndrome, again, blood pressure, 2 lipid values, the triglycerides and the HDL, the waist circumference, and the blood sugar. So those are the criteria there, like you said. I think
what was it, 2 out of the 5, or is it 1 out of them plus 2?
No, I think it's 2 out of the 5. Actually, now that you say that, for a moment, I'm questioning myself, but I'm pretty sure it's 2 out of the 5.
Okay.
And I want to say, I'm almost in my mind thinking 3 out of the 5, but I think it's 2 out of the 5. I'm gonna have to, as soon as, this is what sucks. You question yourself, even though it's something you look at every day when you're in the hot seat, and I'm getting the hot seat at the moment. Okay. So I don't have anything else. I was gonna let you out of the hot seat unless you have any questions for me.
No, that's it. Thank you so much.
All right, good job. Let me just mute you, and then what I'm going to do is I'm going to see where we stand as far as other questions. Let me just see, I kind of lost you here on my control panel. Okay, I'm going to look through, see what do we have in the way of questions, because I saw a couple of question marks. Hold on one second. Dr. Cabby, did you have a question?
No, I don't. I just looked at the heart.org website and they said 3 or more.
3 or more, thank you. All right, I appreciate it, thank you. All right, and I think there was another question mark. Let's see here. Sorry, I'm having to scroll through the list of all the attendees. That's what's taking a second. Dr. Khan, did you have a question?
No, similarly, I was just mentioning at least 3 out of the 5.
Thank you. All right, let's see here. So I think that covers the questions that we had. We still have a little bit more time, so let's get somebody else in the hot seat. Dr. Buttigieg, are you there?
I am.
Okay, if I come to you next?
Yeah, let's do it.
Okay. Which list do you want me to pull up?
We can, whatever we're on next. I kind of lost. I'm like, is it OB or guy?
Back to OB, yeah, how about that?
Yeah, let's do it.
Okay, let me just scroll down here till I find it. There we go. I'll tell you what, let me ask you about case number 5.
Sure.
So this patient had a seizure disorder predating her pregnancy.
She did.
And when you think about a patient with a seizure disorder in pregnancy, tell me about your approach to management.
Yeah, so when I see them for their first prenatal visit, I talked to them about kind of when their last seizure was, what their seizures are like, what medications they're taking, and any recent change in dosing. I ensure that they are being seen by neurology and that they've discussed the pregnancy with their neurologist, because based on kind of metabolism changes in pregnancy, sometimes seizure medication dosing needs to change throughout.
Do you have a preference about what medication they're on?
As long as they're on one that's not teratogenic and they're having good symptom control on that, the preference would be to stay on what they're currently on.
Do you have any idea what this patient was on?
She, I believe, was on Keppra.
And does keppra cross the placenta?
I don't believe so.
Are there any risks associated with keppra during pregnancy?
Not that I can think of offhand.
You mentioned that I think you mentioned that the drug level may change during pregnancy.
The metabolism.
Metabolism, yeah. So with that in mind, how do you monitor a patient regarding the amount of medication that she's on?
Yeah, so again, in consultation with neurology, you would monitor their drug levels and then adjust dosing based on that so that they're in a therapy.
How often would you do that?
I believe with this patient, we did it once a trimester.
Is it okay for the patient to breastfeed?
It is.
How do you decide with a seizure medication whether or not breastfeeding is acceptable?
In general, with breastfeeding, I consult a reference such as LactMed to look at kind of the safety profile of the medication.
And with keppra, are there any side effects for the newborn who's breastfeeding?
I believe there can be some amount of what is it, like neonatal, like decreased activity. I don't know how to say this or how to describe this correctly, but like kind of monitoring their activity level and their alertness.
Okay, so there was just a few questions, and I'll just kind of fill in what I know here.
Yeah.
Starting with the last question about breastfeeding. So some of the symptoms that can happen with keppra with breastfeeding, kind of like you were saying, they're about activity. One of them is hypotonia, where the patient is has like sort of like muscle weakness a little bit.
Yeah.
They can have decreased suckling. They can have weight loss. They can have vomiting. But relatively speaking, it's safe, so it's not considered contraindicated. And the way that they look at that is actually at the relative infant dose, I think is the term that they use. And they sort of calculate the amount of medication that enters the breast milk.
Okay.
It's less than 10%, then they consider breastfeeding to be acceptable. And I think with keppra, you look it up, I think the number's around 8%, if I remember correctly. But the bottom line is, still, there are some potential side effects, and so you have to keep that in mind with a mom that's on keppra. During pregnancy, it does actually cross the placenta. There are not, when you look at the risk of all congenital malformations, there's not an increased risk. There are some concerns maybe that there could be specific malformations that might be increased risk, but there's no data to really clearly define that. So keppra is considered safe. It is associated with small for gestational age fetuses. And also,
that's why I was getting growth ultrasounds. I just like blanked.
Yes. And it's also associated with lower APGAR scores, I think is the other thing. Which kind of goes with that whole like activity of the fetus kind of thing, but I'm not sure if that's a valid way to describe it. It's a good way to remember it, but may not be the best way to.
I'll take it.
Yeah. monitoring Q trimester, I think, would be the minimum. And then when you have dose adjustments, then you might check values more frequently. One thing I will say about kind of my general goal, and I think this is something I learned a long time ago, and I think it's still current, which is when I have a patient with a seizure disorder, not only am I interested in what medications they're on, but preferably monotherapy rather than multi-drug therapy if possible.
Yeah.
I mean, the number one priority is definitely control, but with monotherapy if possible.
Okay.
I think those were the key things I asked you. I don't know if you had any questions for me before I let you out of the hot seat.
No, that's helpful.
All right, good. Thank you very much. I'm going to let you out of the hot seat here. And now I've got a bunch of questions. So let me just answer those. Dr. did you have a question?
Oh, I did a lot earlier.
Sorry.
Regarding vaginal candidiasis, my understanding was that somebody has vaginal symptoms, it's likely they have some on the vulva as well, and to treat concurrently with both PO flagyl and, fluconazole and triamcinolone nystatin combination cream. Is that still the case?
So I think there are multiple treatment regimens that have been described. I don't know that that's an absolute that you have to do it that way. So again, my feeling about that is that you probably, and I'm going to have to defer to looking that up when we get off the webinar, but my feeling is that you're going to find that there are multiple different regimens and that none of them are absolutely preferred over the other. I do know that there is a concern that when the patient's very symptomatic, that you should think about possible, like we talked about, BV and yeast at the same time. But I don't remember the regimen you're describing as being preferred over the others. So okay. I apologize if I have that wrong, but I don't remember that. Okay?
That's fine. Thank you.
Yep. Dr. Faraci, did you have a question?
I did. It was more of, well, this is like way back. We were going over menopausal symptoms or the patient with menopause and the, I guess, the benefit of doing an FSH. In my practice, we usually do a hormone profile. We call it the amenorrhea profile. Usually when, patients come in with some form of abnormal uterine bleeding or with, kind of like menopausal symptoms, we tend to do just a hormone profile. And that includes, FSH, LH, prolactin, TSH, HCG, DHEAS, and things like that. So I tend not to get just one sole hormone like FSH. So how would I be able to kind of defend if a patient came in with menopausal symptoms saying that I ordered a amenorrhea profile when really maybe what I just need is the FSH?
Well, actually, here's the tricky part. What the examiner is going to be thinking is if you have a patient in the late 40s or early 50s who presents with symptoms consistent with perimenopause, you don't really need any labs. So that's really the tricky part, is that there is a concern about the overutilization of labs and tests, and specifically for the diagnosis of menopause. Specifically menopause, the preferred diagnostic criteria is clinical, 12 months with no bleeding. And there are situations where labs can sometimes be suggested as being helpful, like for instance, the patient who's having hot flashes in her early 50s who has a levonorgestrel IUD and hasn't had a menstrual cycle in years. But I still would argue that a lot of that the examiners are going to favor going with the clinical scenario and not wasting time and money on labs. So that's, I think when you have a patient with amenorrhea who's not having the age and symptoms of menopause, then your evaluation makes sense. When you have a patient who's in the right age group with the right co-symptoms, then doing the lab testing is not recommended. That's really the bottom line. So it can be hard in the exam to defend. If the patient's 51 years old, she had hot flashes and amenorrhea, she's menopausal, if she's been 12 months. There's no need to do the hormone profile.
If she hasn't been 12 months? And you're trying to
So,
exclude other causes, like maybe hyperthyroidism
yeah,
or like
so
hyperprolactinemia or something like that. Like,
I think specific tests could be defended if you can give a differential, but when you get back to the FSH, so what if she's 48 and she's not amenorrheic, but she's having hot flashes? If you're doing the FSH, it's probably going to be elevated. And there's no scale of elevation of FSH to tell you, that you're going to treat her any differently. So again, there's I think a real preference in patients who are in the perimenopausal and menopausal age range only to order tests when they actually have a direct impact on management. And
okay,
I could argue that FSH in those patients is not particularly helpful. And that's where the examiners will be coming from. Okay?
okay, thanks.
All right, good. Yeah. All right, with that, I am going to wrap it up for tonight. I want to thank everybody for joining us. It is Tuesday. We will have a structured case webinar tomorrow, Wednesday, October the 5th. Please join us then. Have a great night.